is Wendy, and I'm a new Duke faculty member. I spend 90% of my time in Eldoret, Kenya, and come back to Durham. Hey.
Hi.
How are you?
Good. How are you doing?
Good. This is one of my Eldoret colleagues, Paul.
Hi. Wendy's your mic on?
I think it is. I don't know.
Sorry.
Okay. So I spend about 1 month out of the year back here in Durham, and this is my first extended visit to Duke. I've been here since the beginning of this month, and they've really managed to condense a lot of meetings and a lot of seminars into a very short time. So quite frankly, I'm really tired of hearing myself talk. So I thought that this would be a great forum, since it's a much smaller group, to just put up some slides and then get a discussion going. And so the stuff that I'm going to show you today is not a completed study or a complete picture in any way. It's just some data. Actually, most of it's not published, and just to get some discussion going and hear your thoughts and feedback. So my sort of area of expertise, if I have to categorize myself, as malaria. But I think a lot about access to healthcare because the way that we diagnose and treat malaria can only really be thought about in the context of the delivery mechanism, which in our context is the government health system mostly, and also the retail sector, so pharmacies and medicine sellers. So I started to really think about this issue of access to healthcare once I moved to Kenya, and I was looking at drug treatment strategies for malaria. And I've been in Kenya for 4 years, and I've actually lost or nearly lost 3 friends, not from any sort of strange tropical disease or malaria, but just because of poor access to healthcare. And so I think this is something that's near and dear to my heart. Things that these people died of wouldn't have been an issue if they had been in the U.S. So just thought I'd generate some discussion around this issue. So when you hear access to care, access to health, what does it mean to you? Like, what kind of topics does it evoke?
Affordability.
Affordability, yep, that's definitely an important one. Are there markers?
Markers right here.
Oh, thanks. Yep. So money, like sometimes we hear this referred to as financial access. What else?
Infrastructure.
Yeah, infrastructure.
Medical literacy.
Yep. The patients or the doctors?
I was thinking patients, but I guess either.
Yeah, so trained professionals, and also health education. What else?
Shared technology, patents.
That's a good one. That's really an international problem rather than a local problem generally.
Are we talking about access to health or access to healthcare?
Well, I think people don't really separate those as much as they should, and you're right. So when we think of access to health, or when I think of access to health, I think of lots of community-based necessities for good health, like sanitation, safe water. But most people who are working in this field, when they say access to health, they generally mean access to an intervention delivered via the health system. But they're both, I think, important aspects of this problem.
Will you write the definitions, or will you write what you just said about the second definition? That it's access to.
I'm going to read actually some definitions from. Okay, so a lot of times when you look at the literature on access, they divide it into the supply side and the demand side. And so things like health education, this would go under the demand side, right? And financial access, I guess this sort of belongs in the middle. Infrastructure, this is on the supply side. We also think about things like availability of medicines. And responsiveness of the health system to the community needs. So it's a really complex problem, and obviously it's very cross-cutting. So it requires solutions and ways of thinking about the problem that cut across multiple disciplines. I guess I'll just stand up. So let's see if this works. Okay. So the Alma-Ata Declaration of 1978 was a group convened by WHO, and in this declaration, they encouraged, they basically laid out a definition of health, and they really sort of formalized this idea of health as a human right. And so they said in their declaration that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, and it's a fundamental human right. And then they called on countries to think about or to provide for their citizens access to health. So this should include at least education, promotion of food supply and proper nutrition, adequate supply of safe water and basic sanitation, maternal and child health care, immunization, prevention and control of locally endemic diseases, and provision of essential drugs. So this gets at what you were asking, Erin. Are we talking about access to health or access to health care? And so the Alma-Ata Declaration was very clear about health not just being the interaction between an individual patient and the health system, but it starts with things as fundamental as education and nutrition and safe water. So here's when we look at the literature, here are things that are often discussed as barriers to accessing health, or specifically in this case, health care. And we think about the demand side. We think about physical access, financial constraints or financial access. We think about education, health education, or awareness. There's also cultural beliefs that are really important in the way that the consumer or the patient seeks health care, and the perceived quality of the care that's offered. And on the supply side, we often talk about staff availability, so whether or not we can get doctors and nurses in these rural hospitals and clinics is a big issue in Kenya. We talk about the quality of care, the availability of drugs and equipment and other appropriate technologies. And one that isn't talked about a lot but is actually a really big issue is this idea of management capacity and the flexibility of the management to respond to the needs of the local community. So in Kenya, and I'm really going to mostly just speak about what I know, which is Kenya, the district health management team has very little flexibility to respond to the needs of the community. It's theoretically decentralized, but it's still very centralized in the sense that the requirements and the targets are set at the national level, and the district health management team really can only respond to what the national level requires. And the other problem that we see in terms of management is that the Ministry of Health is mostly staffed with physicians, and they actually have no training in sort of managing and supervising, hospitals and networks of health centers. So just to give you an idea, the Ministry of Health has 2 national level referral hospitals, and then there are provincial hospitals and district hospitals. So there's 1 district hospital in every district. And then you have health centers and dispensaries. And health centers have laboratories. They're supposed to have laboratories. They're supposed to have a few beds and capacity to do deliveries. But dispensaries don't have laboratories. They're basically just a pharmacy where you can get immunizations and sometimes A and C checkups, and there's usually just 1 nurse at a dispensary. So it's this network of increasing levels of care, and that's where most Kenyans seek their health care. Okay, so I thought I'd just give you a little bit of background to Kenya. So Kenya gained its independence in 1963. It's got about 38 million people with a GDP of $1,400. This I think is a little bit misleading because actually if you look at the wealth divide, the 10% of wealthy households earn 42% of incomes, and the 10% of poorest households earn less than 1% of income. So there's a huge wealth divide, and this creates a lot of problems. There's big disparities in health across that wealth divide. The median age of the population is about 18 years, with a life expectancy of about 54 years. And the annual health expenditure per capita is around $6 US. East Africa spends the least amount of money per capita on healthcare of any malaria endemic country. Don't ask me why I know that, but so the national investment in healthcare is actually remarkably small. In terms of health indicators, there's also an urban-rural divide. So about 35% of women in a rural area deliver with the help of a skilled professional, whereas 72% of women in an urban area. Again, looking at children sleeping under a bed net and infant mortality, there's disparities across the urban-rural communities. And again, and it's the opposite with HIV prevalence. We have about 12% prevalence in the urban areas and 8% prevalence in the rural areas. And actually, this isn't a great representation of the HIV situation because what you see is that communities around the lake have between 25 and up to 40% prevalence, HIV prevalence. But communities in the northeast, nomadic communities, especially in the northeast, and on the coast where you have very high percentage of Muslim communities, the HIV prevalence is much, much lower. So this average is by no means like a universal average across Kenya. It's very heterogeneous. In terms of the burden of disease, we see that the infectious diseases like diarrheal diseases, tuberculosis, malaria, they're in the top 10. But we also see cardiovascular disease and cancers coming up. So the burden of disease is definitely of sort of chronic disease is definitely growing in Kenya. But for kids, still respiratory infections, malaria, and a lot of very early perinatal and neonatal conditions represent the largest burden of disease in kids.
Wendy, when we look at data like that, how much of it is data that's captured through the formal health system, and how much is sort of trying to estimate what,
So this is from the WHO, and this is most definitely through the health information system provided by Kenya.
So numbers might be underestimated.
There's certainly a good deal of miscategorization, I'm sure. And we know, for example, in the place where I worked on the coast, that 30% of kids die at home without ever contacting the formal healthcare sector. So those, that fraction of people that, that die or suffer severe disease without coming into contact with the health system, we don't have any information about them. So there's no vital registration system. This is a map of Kenya, and each blue dot is a government or a mission health facility. There are about 5,000 government and mission health facilities. This is a little bit misleading because the vast majority of these dots are dispensaries, so places where you get very, very rudimentary services. Then if you look at distance of populations to their nearest health facility, you come up with a map like this. And so about 80% of Kenyans live within 5 kilometers of their nearest health facility, whether it's a dispensary or a health center or a district hospital. But the interesting thing here is that although 80% of Kenyans live within 5 kilometers, that 80% is in 20% of the country. So again, there's this huge heterogeneity in access to care, and it largely falls, again, along poverty lines, with the northeast part of the country being extremely poor and politically disenfranchised and having very limited access to health services. Maybe Dudson has anything to add to my summary of Kenya's health system, since he's worked in it as well.
Yeah, that's my home country. So the other thing is, I was thinking about as one of the barriers to access is the asymmetries of information that exist. So basically, the healthcare personnel would not exactly give you all the have all the time to give you all the information that you need, so that you could continue and get all the care you want. And I think that plays out quite significantly in Kenya, even in the private sector, where you pay premiums and they're trying to do as best as they could.
So you mean communication between the patient and the provider is inadequate?
Yeah. And then regarding the distribution, this is fairly representative about the health facilities. In the most populous areas, which tend to be towards the center of the country and the western part, you have many facilities, but they're very basic, really. Dispensaries at best. And over the northern frontier, there is very low density in terms of populations, and also they are disenfranchised because of the long political disparities that we have concerning the people who live in the north. And it's political, really. Since independence, they've always been much lower. So it's fairly representative, I would say.
Okay, so any other questions or comments?
So in addition to the political disenfranchisement and the different cultural and political things that are going on that exaggerate this disparity, do you think that the burden of HIV near the lake has increased that disparity, because funding flows and things go to where the areas of HIV prevalence are the highest?
I don't know. I don't have any data about that, but it's a good question.
I think most of what you'll get about Kenya will be on the lake side, because that's where the CDC has moved to. They're collecting information from that point. You don't have any information coming from the north.
You don't, And the roads are really bad. There's very poor, just infrastructure and physical access for all kinds of services, not just healthcare, up into those communities as well.
So there's a lot of information that you will never know on the northern side, and even down the southeastern part. You will never get to.
Did you want to say something?
My impression is that a couple of years ago, when there was all the election violence, it was focused in the west, but did any of that spill over into the north or south?
No, I don't. No, the political violence is really concentrated in this area, and a little bit in Nairobi, but no, it was really very focal. It was very, very focal. Even on the coast, it was quiet. There was one day of looting, and then people on the coast have a reputation for being very superstitious. So then people started feeling that the things that they had stolen were cursing their families, and they started bringing them back to the stores. So, no, it was very, very focal. Okay. So I just wanted to, sorry, these aren't very pretty tables, but I picked them right off of the templates that the district health management teams have to fill out to report back to the national level. These are the indicators that the National Ministry of Health has developed to measure their progress towards good access to care on the supply side. So these are the only things that they care about from the districts. These are the only things they care to know. They want to know how many women are getting preventative treatment for malaria during pregnancy. They want to know how many pregnant women are having 4 antenatal visits, how many women are receiving family planning, the number of deliveries conducted at the facilities, the number of HIV-positive mothers receiving prevention of mother-to-child transmission services, and bed nets distributed to pregnant women. And then they want to know how many kids are born with low birth weight. There's very little data on this because very few babies are born in the facility. The number of newborns receiving BCG, extremely high BCG immunization coverage across the country, more than 95%. So, number of children under 1 fully immunized. This tends to fall between 75 and 85%, so still pretty good. Number of children under 1 vaccinated against measles. Children receiving vitamin A. Underweight children visiting health facilities. And growth monitoring, insecticide-treated nets distributed to kids, children under 5 treated for malaria, over 5 treated for malaria, and the number of school-aged kids that are dewormed once a year. And then for if you're not a child under 5 or a pregnant woman, then all they want to know is HIV-positive cases that are on treatment, number of people who voluntarily come for counseling and HIV testing, TB cases detected, TB cases cured, and completed treatment. So this is what the National MOH wants to know from its district about how well they're serving the communities. That's it. Okay, so I'm going to talk a little bit more in depth about the 2 places in Kenya that I've worked, and they're very, very different. One is right here on the coast of Kenya. This is where I worked the first 2 years I was in Kenya, and I'm now in Eldoret working in Western Kenya. So this is some data that I compiled from the district hospital in Khalifa, and what I did was for every admission, I looked at whether there was an intervention available for the cause of that admission. So if there was a preventative intervention that could have prevented that admission, if there was a treatment intervention that could have been applied at the primary care facility that would have prevented that hospital admission. And so the fraction of, we had about 30% of our admissions were due to malaria, so we considered that anti-malarials or ITNs could have prevented that admission. Sanitation, zinc, vitamin A, breastfeeding, nutrition and growth, clean delivery, so a large fraction. The blue bars are admissions and the red bars are deaths. So somewhere like 20% of our deaths were things that could have been prevented by having skilled attendants at delivery. Then the vaccine preventable diseases are very low on the radar. We had just introduced HIB vaccine not that long ago. All the other EPI vaccines, we had a couple of measles cases and a couple of tetanus cases, all neonatal. But basically the take-home message is that for only about 10% of admissions was there no prevention intervention available for these admissions. So that means 90% of the admissions potentially could have been prevented. But for a large fraction of admissions, there's no treatment intervention available, and these were mostly malnutrition and neonatal problems. So this tells us that there really is a breakdown of this network of dispensaries and health centers that's supposed to be reaching the communities with these interventions. And so there's a picture of access, or at least uptake, that was pretty disturbing. So just stop me if you want to jump in anywhere.
Can I ask you a question? So this all falls on the supply side of healthcare.
Well, it falls on, it depends, right? So things like immunizations and anti-malarial drugs, we have problems with stockouts. But things like going to antenatal clinic and delivering in a facility, we have both problems with adequate capacity at the facilities, but also problems with moms not wanting to deliver at the facility or not being able to walk 10 kilometers while they're in the 3rd stage of labor.
So then when they show up, they appear.
So yeah, maybe I should show you a map of it. Let me just show you. So this is the district. This is with all of its little administrative interior boundaries. Each of these is a primary health care facility, a dispensary or health center. And then right here at the center, this is the Indian Ocean. Right here at the center, this is the district hospital. So kids who wind up at the district hospital often have some contact with one of these peripheral facilities, and certainly they should have received like their immunizations at one of these peripheral facilities. So I was looking at who winds up admitted to this hospital, so severe, with an illness severe enough that they have to be put, admitted to the hospital to receive care. Does that clarify?
Yeah, that helps a lot.
Okay.
So it's a combination of supply and demand.
Yeah. Yeah, definitely. And so looking at this kind of disease burden gives you a picture of the combined, effect of problems on the demand side and problems on the supply side. So this is, so this is the district, and this is the district hospital. We know that 85 to 90% of the admissions to the hospital come from within these boundaries. This is the ocean here. This is, there's a road that runs right along here that goes from Mombasa, which is the largest port in East Africa. It's about another 10 kilometers down here. And there's a road that runs right through, right past the hospital, all the way up to Somalia. There's a creek right here, a big tidal basin that comes in right here, and there's a national park right here. So just to give you an idea of what the boundaries of that catchment area look like. This is the admission rates calculated for each of these little administrative zones to the hospital, and you can see that areas closest to the hospital have the highest admission rates. But I guess not surprisingly in retrospect, but when we first looked at it, it was sort of alarming. The highest case fatality once they get to the hospital are from these areas that are further away. So this is indicating that either people are waiting later until their kids are sicker to make the investment to come to the hospital, or it's taking them a long time to get to the hospital, or it means that these facilities that are out here in these communities are not providing adequate care, and more kids are winding up very sick at the hospital. Yeah.
Did you consider the poverty index of Khalifa? It's one of the very...
So yeah, Khalifa is the second poorest district in the country. It's very rural, and it's mostly subsistence farming and fishing. There's only one peri-urban center that's kind of concentrated right here around the hospital, but the rest of the population, it's pretty homogeneous in terms of their resources and their opportunities for education and employment, and it's pretty dismal. So
this is further up the coast from Malindi.
Malindi's actually up here.
So it's between Malindi.
It's between Malindi and Mombasa. Yeah.
Is it still a one-lane road?
Yeah, it is. Yeah, it's a scary, scary road to be on at night because you get all these Somali truck drivers who pick up their payloads in Mombasa, and then they start driving at night, and like the windshields are hanging out and they're all hopped up on cot and going 100 miles an hour down this one-lane road. It's awful. We try never to drive that road at night. Okay. So we saw sort of a similar picture when we looked at neonatal admissions. So about 30% of the admissions to 25% of the admissions to the PEDS ward were neonatal admissions. And they had extremely high case fatality rate, like basically 50-50 chance of survival. So preterms, birth asphyxia, neonatal sepsis, neonatal tetanus, all really huge problems in this area. And so what we saw was that if we looked at kids who died on the day, were admitted on the day of birth, they tended to be closer to the hospital or to this main road. And then if you look at admissions within 1 week, you see more coming from further out. And if you look at admissions below 60 days, now we're starting to see a lot more kids coming from these interior areas. And clearly we know that it's not that there aren't any neonates with problems in these areas. It's just that getting from here to here in 1 day, if your child is born with problems, is almost impossible. And so what we're seeing here is probably an undescribed, very high burden of neonatal problems, but that are never making it to the hospital. And then as you get to a little bit older, 7-day-old babies or 60-day-old babies, then you see them coming from from all parts of the district. So, let's see. Oops. So we started thinking about, these type of problems. Sorry, these types of problems can't really be corrected by improving hospital care. They have to be fixed by improving care in rural areas at these, through these smaller health facilities. And so we wondered, what is the physical access to these primary care facilities like in the district, and is it a significant factor in morbidity and mortality in our kids? So what we did was, so again, this is the district. Here's the hospital right here in the center, and these are primary care facilities, so clinics and dispensaries in the rural areas. And we calculated the traveling time. So we have a complete household census in this area, so we know where all the households are. And the really cool thing is that these kids, when they come to the peds ward, they're linked to their household. So we know where every single admission to the pediatric ward comes from. So we know where every case of diarrhea, every case of malaria, every case of malnutrition, we know what house they come from and where and we have we have each house geolocated, so we can map them. So what we did was we calculated the traveling distance for every household to their nearest peripheral primary care facility. And we also have a road and footpath network. So we just built a very simple model that constrained these people to go from their household to the nearest facility along this road network. So this isn't like Euclidean distance as the crow flies. This is actual walking time from their home to the nearest primary care facility. And we also constrained them to go around to the nearest bridge when coming to bodies of water and things like that. And it turns out that this is, I can give you some references if you're interested, but this is a much more accurate way to describe physical access is through this traveling time. So what we saw was that about almost 70%, about 65% of, so I think it's something like 72%, I can't remember the exact number, 70% of kids live more than an hour away from the nearest primary care facility. So this is where they have to go for their immunizations, this is where they go when they get a fever, and they live more than an hour's walk to the nearest primary care facility from their home to these rural facilities. And the average in Kenya is about, like we said, 80% live within 5 kilometers, which is about an hour's walk. So it's definitely below the average here. Then we wanted to know if we could measure the impact of physical access to these facilities on morbidity. So first what I did was I took all the malaria admissions. I'm sorry, this is really hard to see. But I took all the malaria admissions to the hospital and I mapped them out. And I created a density map that's corrected for population density to see if there were hotspots of malaria cases coming into the hospital. And we started this analysis for other project that we were doing, but it turned out to be really informative. We were trying to help the district health management team decide where to put new facilities. So we wanted to identify areas that had hotspots of poor access, and if that was reflected, especially if that was reflected in the disease burden. So I don't know how well you can see this, but if you look like along this corridor that has people walking a pretty far distance to get to the nearest primary facility, you get this hotspot, and then on this side you get this hotspot of high malaria admissions into the district hospital. So we thought, and also this area is right here, and this one is right here. So we thought we might actually see an impact of access to these facilities on disease burden, and we did. So when we calculated the incidence of hospital admission for malaria as a function of traveling time to the nearest health facility, we saw that the incidence of hospital admissions for malaria went up by about 2.5-fold as you go from about a 10-minute walk to the nearest facility up to about a 2-hour walk to the nearest health facility. And what was kind of cool about this analysis was that it allowed us to calculate something like a protective efficacy of the primary healthcare system. So how many disease episodes could have been averted if every kid only had to walk 1 hour to their nearest facility? And we were interested in doing this kind of calculation because a lot of times, donor agencies and governments, they avoid investing in health systems infrastructure because the impact is really hard to quantify. Right? It's much easier to say you delivered 1 million bed nets, you gave out this many doses of drug, but measuring your impact on health systems investments is much more difficult. So now we could actually calculate how many episodes could have been averted by good proximity, good physical access to primary care. And we saw that it was about 38%, so 38% of hospital admissions could have been avoided if every kid lived within an hour's walk of their nearest primary care facility. And when we line this up with other biomedical interventions for malaria, we saw that primary access, physical access to care actually stacks up really well. So RTSS is the malaria vaccine that's in the furthest stage of development. It's currently in multi-site phase 3 clinical trials, and it's shown about 30% efficacy against severe or hospitalized malaria. And IPTI, this is an intervention that you give kids therapeutic doses of malaria drugs at the time of their routine immunizations. So regardless of their infection status, you give them a dose of drug. And usually it's a very long-acting drug, so a drug with a long prophylactic window. And we see that it has about 25% efficacy, 25 to 28% efficacy in reducing episodes of febrile malaria. And this is kind of what you would expect if you give a kid 3 times a year a dose of drug that protects them for about a month. But the bone that I have to pick with this strategy is that this strategy is predicated on poor health systems, right? So you give kids a dose of drug to prevent malaria because you think you might not see them back at that health facility and get the chance to treat them if they do come down with malaria. If you knew that you would see and treat most fevers, then you would never use this strategy. You wouldn't be giving out antibiotics to school-age kids in the U.S. for, to prevent against strep throat. And so I think this strategy, I think there's definitely a place for it in the short term, but I think the long-term view has to be to invest in health systems to a point to make these kinds of strategies obsolete. Okay. Any questions or comments about talking a lot here?
Is it enforced yet, the intermittent prophylactic treatment for kids?
Is it what?
Is it enforced?
It's not in Kenya yet. The WHO did not fully endorse IPTI. The Institute of Medicine was asked to review it as a strategy, and they gave a more favorable review. I spoke before that committee. They gave a more favorable review, but it's not. I think there are very few countries that are using it. It doesn't have as much benefit as in pregnancy. The problem with pregnancy-related malaria that's different is that you can have placental malaria that causes low birth weight and anemia for both the mother and the baby, and you can't detect it in the bloodstream. So you give preventative or presumptive therapy for placental malaria because you can't always see the parasites in the bloodstream, even if they're at the placenta.
Have you made some of these similar estimations and calculations for other diseases? Because you're going to set up a health center. It's not just going to be a malaria test, right?
We could. So we saw. I don't have the slide, but we plotted other. Basically, we broke it down. Malaria is the largest single cause of admission at the hospital, right? And that's changing. It's definitely declined a lot. But it's the largest single cause of admission, so it made doing this kind of analysis, it made the errors reasonable because we had, spread over this geographic area, we could calculate incidence with reasonable confidence intervals to say that there was a change. I did the same thing but took all non-malaria admissions, and you still see an increase, but it's not as pronounced, right? So these are a mixture of things that can and can't be prevented at the primary care level, like malnutrition is not going to be treated and prevented at the primary care level. That's a community problem, right? But other things like bacterial pneumonia and things like that could be prevented at the primary, or they could be handled at the primary care level. So you see this kind of intermediate curve like that. out.
Yeah, absolutely. My other question is, did you try to model or try to map out what it would look like to have health centers within an hour's walk, for example, every...
Map out, like, identify the locations where we put them?
Yeah, because from that map we can't see like where the paths are versus the roads and where the stream crossings are. Maybe it's just a matter of putting in bridges.
I should have put
versus...
So definitely creating so first of all, I'm a big believer that increasing transport infrastructure is a very effective health intervention.
Yeah.
And so I totally agree with you that improving the transport network, especially right around, so this is a big body of water right here. So improving the transport network on the backside of this big body of water would be a huge improvement. You know, you don't even have to put a facility there. Well, actually there is a facility there, but getting to the hospital is the problem. So what we were doing with this, actually with this analysis was working with the district health management team, and Kenya started this program called the Community Constituency Development Fund. So every member of parliament's constituency got a certain amount of funds, and they would write a proposal for how they wanted to use those funds. They'd write a budget, and you could use them, a lot of communities use them to build schools or build health facilities, or dig a well, or put in a water pump or something. And a lot of the communities in this district use the money to build health facilities, right? The problem is that this project wasn't coordinated with the Ministry of Health. The Ministry of Health had no money to staff or equip these health facilities. So you had all these empty health facilities. Like there was no recognition, there was no agreement between, you know, the Constituency Development Fund and the Ministry of Health or the Ministry of Education that if the community built these facilities that they would be able to staff them. So you had all these empty health facilities, and so we were trying to decide, okay, if we can raise the money to staff and equip one health facility, which one should it be? So we're trying to use some of these tools, these spatial analyses, to help the district health team decide how they could best serve the communities based on access to care and disease burden at the hospital.
So you have been presenting your results to the authorities?
Yeah. We worked really closely with the district health team on these projects. But this stuff, well, this analysis has been published, but this stuff hasn't been published. All this stuff not published. That map we published. We haven't published this. This was an interesting study because we had data from a couple of years, and we wanted to know, and we knew that malaria was declining, and so what we wanted to know was, as malaria declines, does transmission become more homogeneous or more heterogeneous? And as transmission declines, are there very clearly defined hotspots that we could go in and target with our interventions? So I can, if anyone's interested, I can show you that data afterwards. Unfortunately, well,
you could also try 2 different interventions and see which hotspot diminishes the most.
Yep. Unfortunately, there were a lot of studies going on at the hospital that required malaria admissions, and so we didn't have a lot of support to do community-based preventative interventions.
The World Bank helped us in Honduras to staff a clinic. The community organized and put in the application, and then sent the money. They sent the money to the government for 5 years. So
maybe we can talk about how you did that. Okay, so the other side of this that we haven't talked much about is the demand side. And so as part of my work with the district health management team, we went to the communities and we talked to them about what their health priorities were, try to understand how we could incorporate community health priorities into planning at the district level. And so at every one of these facilities on this map, we convened a community health committee, and we met with each of those community health committees to get their feedback on health priorities in the community. So there were 22 committees that we met with, and all of these community committees cited health education needs. Every single one said that the community needs health education around X, Y, and Z. That was across the board. 86% of, that's not really, I should say, like, I think it was like 19 of them discussed severe lack of space, equipment, and drugs at the facility. So they go to the facility, and whatever they came there for, they can't receive any services for because of space issues, equipment, staff, drug stockouts. They were really concerned about the alienation of youth from health services. But distance to the facility was the most often cited barrier to access, particularly for antenatal care and safe delivery. And then they went on to talk, half of these committees, they talked about sanitation, clean water, and environmental management of disease. So a lot of them suggested digging latrines and demonstrations on water safety as priority health interventions in their community. And one committee, they actually, by the time we left, they pledged to set an example by all of the committee digging latrines at their own homes following that meeting. And I'll tell you, if there's time at the end, I'll tell you about a really cool program that was launched in Khalifa called Community-Led Total Sanitation. Have you guys heard of Community-Led Total Sanitation? I bet Randy has. Anyone else? It's good, I'll tell you about it at the end. And also the majority of committees talked about low ANC attendance and home deliveries as a major health concern. The reasons that they cited were different than when we talked to the facilities, and they included inadequacies at the facility, but also fear of HIV testing, because Kenya had implemented mandatory HIV testing for any women going to ANC care, and that this was discouraging women from going. And especially in these communities, there's really no access to antiretroviral drugs or HIV services. So male midwives, they didn't want to be delivered by any male nurses at the facility, and distance. About half said that malaria was a problem for kids, but at least that many also said that malnutrition was a serious problem. And if you remember, malnutrition really wasn't on the radar of the national ministry.
Just go back a couple slides. Can you explain what was meant by alienation of youth and how that relates to...
The communities really felt like the youth were discouraged from coming to the facility and accessing services. So, and that they weren't taken seriously, they weren't given, they're not really kids and they're not adults, and so they fell into this middle ground, and they really felt like the kids didn't feel, or that these adolescents were being discouraged from going to the facility and weren't taken care of by the facility staff. You know, I think it's very daunting for, like, for example, for a teenage girl in this area to go to the health facility and try to access family planning. That's really looked down on, and so they felt that there were a lot of barriers, a lot of cultural barriers to these kids being able to access services. And another thing that they talked about with respect to these kids was drug and alcohol abuse. So a lot of committees said that drug and alcohol abuse were a problem for their teenagers as well as for the adults. There are actually 3 committees that talked a lot about elephantitis, which is caused by lymphatic filariasis. We don't actually have any idea what the prevalence of lymphatic filariasis is in these communities. But again, not on the radar of the government. Nutrition amongst the elderly was mentioned by several of these communities. And again, the problems that they felt were facing adults were sort of balanced between infectious diseases and chronic conditions, and actually quite a few talked about diabetes as a big problem. And then they spent a lot of time helping us generate ideas for how to improve utilization amongst adolescents, including doing school-based clinics and school-based voluntary counseling and testing, and having youth representation on these facility community committees. Yeah.
Wendy, did your committee have pretty balanced men, women, age? Who came out for this these studies?
So this actually wasn't a study. This was an effort by the government to get more community involvement in the health facility. And there was a pilot program going on in the district funded by Danita, where they gave each facility a small amount of money to spend for their facility. It was a very small amount of money, but for their facility priorities. And the government really hasn't invested in maintenance and repair of any health systems infrastructure in about 20 years. So a lot of them were, so the DHMT convened these committees at the facility to get community input on how the money should be spent. So that was the purpose of the committee, and so they were appointed by every village that was around the health center got to appoint one person. And they tended to be like about 30% women and 70% men, but generally like older, more respected members of the community.
Do people identify diabetes by name, or do they talk about symptoms and then you interpret as diabetes? I mean, how much do people
They
know
talked
that?
about diabetes by name, yeah.
And have been diagnosed as such, or I mean, is it obvious?
I'm not sure how the awareness about diabetes, but they understand that, like, for example, if you have diabetes, you shouldn't drink Coke or put too much sugar in your tea. But this is, so I'm not a physician, I'm not an expert in diabetes, but the presentation of diabetes in Kenya is really different than here. You don't have type 2 diabetes, like late onset diabetes, that's sparked by poor diet or obesity and things like that. You get type 2 or non-insulin dependent diabetes, but it tends to be in younger people, pretty fit. So there are a lot of people speculated about like a malnutrition trigger for this kind of diabetes. They call it type 3 diabetes. I don't know, Paul might know more than I do that.
You're teaching me right now. I didn't know there was a different presentation.
Yeah. So
I'm just curious.
But foot care is a big problem. So I think like the danger sign for diabetes at the community level is ulcer wounds on your feet. That's
Yeah, I think the incidence of diabetes is quite high as well. It's not what most people would expect, but it's pretty high. There are communities that have, especially in Eldoret, you'll see, I mean that's on the western part of the country, you'll see lots of type 2 diabetes actually. But this tends to be familial, meaning the one we see, there's a family history. Most of the patients will have a family history of diabetes. And also the type 1s are frequent among the adolescents. We see a lot of type 1 as well. I'm not so sure about the community in Kilifi, but I would think type 2 would still be the one that they're referring to among the adults.
Okay. So, yeah, and just to give you an overview of the community priorities that were identified by the community, but for which no indicator is reflected in at the national level. And the reason this causes problems is because the district health management team, they have a performance contract with the national level, and they have to be responsive to the national level targets in order to fulfill that performance contract. So they almost never invest in activities that are outside of those national indicators. So community priorities that lie outside of those national indicators are the district health management team just can't or doesn't tackle. Right. So diarrheal diseases, skin diseases, respiratory infections, bilharzia, jiggers, snake bites. Jigger is actually a huge problem in Western Kenya when we do this door-to-door home-based counseling and testing. Sometimes these kids, you can't even find anywhere to prick on their finger because their fingers are just huge with jigger infestations. It's a huge problem. Amongst adolescents, early pregnancy and drug abuse, and adults and the elderly, eye problems, hypertension, filariasis, diabetes, arthritis, drug and alcohol abuse, and nutrition.
What are the numbers in parentheses?
The number of committees that independently identified that health situation. Okay, so along these same lines, so there was a recent study that came out of the CDC team in Kisumu that showed that overall under 5 mortality could be reduced by 12 to 15% if children were treated according to IMCI guidelines for their true underlying cause of visiting the primary care peripheral health facility. So we're looking at how to increase correct diagnosis and treatment for malaria in peripheral health facilities, and also working to try to describe the other underlying causes of non-malaria fevers. And then we're using data from a huge household survey to try to identify reasons for low uptake of preventative interventions and poor treatment-seeking behavior. So we have 2 household survey databases that we're analyzing, and we want to know whether the reasons for high uptake of preventative interventions are different than why they have good health-seeking behavior or treatment-seeking behavior, and if people consider potential future disease events when they're thinking about investing in prevention. And looking at whether financial or physical access is a greater barrier, and if we can identify populations at risk. So I'm pretty much out of time, but I have a little bit of preliminary data from those databases. Basically, I'll just point out the highlights. We saw that the likelihood of being a defaulter, so the likelihood of not finishing your immunizations as a child, is related to your socioeconomic status, but it's also related to whether your nearest facility is a dispensary, a health center, or a hospital. So if your nearest facility was a hospital or health center, you're more likely to finish your immunization than if it's a dispensary. And we think this might be pointing to stockouts, problems with keeping immunizations in stock at the dispensaries. They tend to be like the lowest on the totem pole when it comes to... And then we looked at pregnant women, so we identified all the pregnant women in these cross-sectional surveys. Amongst about 20,000 women, we identified almost 1,200 pregnancies, and only about 50% of them had ever attended ANC. So these were self-reported pregnancies. They're almost all late second trimester, third trimester. And so the fact that 43% of them had never attended an antenatal visit is kind of alarming. Here, we didn't find distance to a facility as being significant, but again, the type of facility that they were nearest to did have a large impact, and as well as age had a significant but very small impact. So, but the thing that really concerned us is we found that pregnant mothers who were not attending antenatal clinic were 3 times more likely to be HIV positive. So there's a huge group at risk that's not having any contact with the health system. And of course, so this is of course a target group that we really need to pay attention to. So yeah, that's it.
Yeah, so with all the issues of geographic and proximity, transport, I know in Eldoret, there's a lot of interventions trying to take community health workers and bring care to the people in the rural areas.
Yeah.
What have you noticed as far as the buy-in from the Ministry of Health? Is like, are they buying into this concept of funding community health workers, or do you think there's some resistance to the question?
So there's a national policy around community health workers in Kenya. So it is national policy. They're trying to implement community health workers, but they haven't allocated any money to the program. So in 2006, they wrote this beautiful strategy for community health workers, using community health workers in the communities. But since then, they haven't invested a single shilling in the program, and they rely on outside donors to come in, and they've kind of done it piecemeal, like, in this district we'll provide community health workers. And there's lots of problems with that model, including the government's insistence that they be volunteer. So having a volunteer workforce leads to high turnover rate, low motivation. So it's not something that's been done very well or very systematically. And the government is completely against, so these community health workers are supposed to have kits that they take around with them. And the government has been talking about these kits for years, but they've never deployed them because they can't agree on what should be in there. And there's some people in the ministry who want anti-malarial drugs to be in the kits, and there's other people who don't want any controlled pharmaceuticals in the kits, only aspirin, for whatever good that is. So it's, there's a lot of debate about whether or not they should be giving out drugs at the community level. Any other questions? Okay, thanks for coming, everyone.